Okay, let me go do that again. Take two. It's my pleasure to introduce our speaker today, Dr. Jonathon Jackson, who is the Executive Director of the Community Access, Recruitment, and Engagement Research Center at Mass General Hospital and Harvard Medical School. CARE investigates the impact of diversity and inclusion on the quality of human subject research and leverages deep community entrenchment to build trust and overcome barriers to clinical trial participation. His research focuses on midlife and late life health disparities in clinical settings that affect underserved populations. Dr. Jackson also works as a cognitive neuroscientist, investigating the early detection of Alzheimer's disease, particularly in the absence of overt memory problems. He has become a well-known representative to underserved communities and dozens of affiliated organizations, particularly regarding participation in clinical research. Dr. Jackson serves on the leadership team of several organizations focused on community health and has written guidance for local, statewide, and national groups on research access, engagement, and recruitment. So his talk today is entitled Mixed Methods Recruitment in Alzheimer's Disease and Related Dementia. Take it away, Dr. Jackson.
Thank you so much for that warm introduction, and it's wonderful to be interacting with all of you virtually. I'm going to try to zip through my slides and leave a little bit of time at the end for questions, or for those of you who are trying to attend two talks at once, maybe you'll have a little bit of time to pay attention to Tony Fauci instead of me. So again, thank you all for being here. And I'm really hoping that there is at least a little bit in today's talk that you find interesting or intriguing. So we'll go ahead and jump in to my disclosures. Just wanted to talk about where my current sources of funding are coming from and where they have previously come from. And in addition to talking about research funding, also highlighted here where our community activity funds come from. But let's go ahead and get started. I think that, those of you who are here on the Zoom, those of you who can see the screen must recognize that this quote from Martin Luther King Jr. is one of the most cited, most well-known quotes when it comes to understanding aspects of equity, inclusion in clinical care and clinical research, and in thinking about the healthcare enterprise much more broadly. And so what I want to highlight here is that we've just passed the anniversary of Dr. King giving this speech just last week back in Montgomery, Alabama, after the Selma marches. And so at the time, I think it's well known that he was talking about desegregating hospitals, fighting for civic rights, putting an end to the Tuskegee syphilis study. But it's really worth reminding ourselves at the beginning of this talk that when we're talking about the culture and the history of abuses, that it is actually fairly extensive. And so actually, I typically have a whole hour-long talk where I can just scratch the surface. I can't even go into significant detail about the number of research abuses that targeted other minoritized and marginalized populations in the U.S. and abroad by research doctors that look like you and me. And so it's worth noting that at the bottom of this very busy slide are the Nazi war doctors at the Nuremberg trials. What is always very sobering to remember about the Nuremberg trials was that, again, the literal Nazis, their primary defense is that they were less bad, that they were more morally right and upstanding than American research doctors, because they only experimented on individuals that were captured in a wartime setting and were thus condemned to death. So just keep in mind that as I talk about principles of equity and inclusion and representation, our starting point is that the Nazis think that we're worse than them. And so we haven't necessarily moved the needle as much as we like to think we have. but we also have just a whole long way to go. Beyond that, I wanted to share just like a brief clip. This is from an old PBS Nova special from 1993. So believe it or not, that was 30 years ago. And in this special, they're talking about events that had taken place 30 years prior to that in the mid-1960s. And so I want you just to bear in mind that this is the narrator talking 30 years ago about events that had happened 3 decades prior to that. Just listen to the narrator and ask yourself whether some of these words might still apply today.
During the turbulent years of the civil rights movement in Alabama, the study went on. The scientists continued to ignore this new force that shook the world around them. Instead, they watched and they waited to see what would happen next to the men of the study.
So I thought that was a pretty illuminating clip. It really was talking about the civil movements in the 1950s and 60s, but we are just a few weeks out from the third anniversary of George Floyd's murder. And, it feels like maybe this particular descriptor applies to us at this moment in time as well. So the more things change, the more they really stay the same. Now, the big question, though, is how and why and when do we try to bring these worlds together? The overarching question is, we've got these principles of health justice, and boy, I think most of us are on board for that. But how do we do that without sacrificing research rigor? It seems like every time we talk about this, there's a tension between these two. And in other words, how can you tell that you're having the impact that you want to have when you have an event like you see here on the left versus an event that you see here on the right? Now, these are two events that I attended, that I spoke at, that were held here in Boston. On the left is one of the events that was organized pre-pandemic by my Care Research Center. And one of them on the right was organized by our local chapter of the Alzheimer's Association. These were two brain health events held about a mile apart from each other. And what you can see is that sometimes you really get it and sometimes you really don't. Sometimes research rigor and health equity seems to go so marvelously hand in hand, and other times we just don't get it. We end up with like a very, very sad event here, like you see on the right, where the attendees were outnumbered by the catering staff 2 to 1. So when you have these questions, I think that they're all reasonable, and many of us find ourselves feeling a little overwhelmed and not quite sure where to start. So for me, I tend to start here with Lasagna's law, which I think rather cheekily says the incidence of patient availability sharply decreases when a clinical trial begins and returns to its original level as soon as the trial is completed. In other words, research investigators, PIs, have no idea where participants come from. They have no idea in what numbers and what volumes and what amounts that those individuals show. And so for me, though, thinking about this, which is effectively kind of a modeling problem, it's effectively a selection problem, is a really important way into understanding aspects of inclusion and representation in clinical research. Now, before I go on, I just want to give just like a quick reminder that when we talk about the importance of diversity and inclusion and representation, this is not just a matter of social justice. Social justice should be enough to try to motivate us. But when it comes to thinking about causal inference in clinical research designs, we recognize that when you don't have a generalizable sample, it will threaten your external validity. But we also know that it undermines the other key validity structures that underpin causal inference and causal estimation. And so all of these citations are, familiar to some of the people in this audience. I do heavily cite the Melodim group and, incredible researchers like Dr. Power. But what we fail to really appreciate is that the science that we are doing now, the science that is not equitable or representative, is not high quality science. It's not rigorous. And the problem, unfortunately, only stands to potentially get worse. So if we look at the diversity and the representativeness of genotypic and phenotypic databases in the United States, not just the United States, but globally, we see that from this paper from 2018, unfortunately, the numbers haven't changed a lot in the last 5 years or so. But you can see that we've only got 3 categories. So first of all, that's a bit of a head scratcher. We've got European, Asian, and, we've got an other category. So problematic in terms of trying to, let's say, adequately capture the richness of different social groups, different cultural identities. But it actually gets worse than that. So the Europeans aren't all Europeans. They tend to be Western Europeans, actually, they tend to be descendants of Western Europeans that are living in the United States, but not just those individuals. It tends to be the descendants of Western Europeans that are living in the United States on the east or west coast of the United States in urban or suburban centers that have a very high income and a master's or a doctoral degree. So the European bar ain't even all Europeans. The same is true of Asian because, like for the love of God, what is an Asian even? And so it turns out that these aren't all Asians. They tend to be specifically thinking about Han Chinese that reside, largely on the eastern provinces of China in urban centers. And so again, they're not even representative of all Han Chinese, not even all representative of all Asians. And then, the less said about other, the better. So the problems that we face in terms of causal estimation are really they threaten to be compounded in the era of big data, where we construct machine learning algorithms in these black boxes that make it a little bit harder to interrogate fundamental assumptions about what the data should be doing. I think a really clear example of our lack of priorities here is to look at the diversity when it comes to recent clinical trials for Alzheimer's disease. So these are the data from Emerge and Engage. So this is for aducanumab, now known as Aduhelm. The data patterns aren't appreciably different when it comes to thinking about the data for lecanemab, but because there are some interesting issues in how they lumped people together, I want to walk through this data example. So we know that Engage and Emerge were, there were trials that were running in 20 countries, 348 sites, 3,385 participants over the range of the trial. And you can see that even though it was by many stretches a global study, we could see that it was nearly 90% white, with white people only comprising 16% of the global population. You've really got to wonder what we're doing here, what we're prioritizing with this. The lack of diversity doesn't stop there. The vast majority of that small slice of Asian participants in red were recruited in Japan. So that doesn't really tell us about the category of Asia. And then if you squint, you might notice that there are 6 categories here, but it's hard to see more than like 4. And that's because there was only one individual that identified as an American Indian and one individual that identified as a Pacific Islander. So again, 3,385 participants, 1 American Indian, 1 Pacific Islander. But we're really here to kind of take a look at this green slice, which are the Black individuals of the study. So this is 1/2 of 1% of the research population. And so that's low by any metric that you might think of. But there's so this is a problem. And I think all of us recognize this. But the wrinkle really emerges when we start to think about racial disparities in representation in the context of APOE. So if we look at kind of the rate of significant side effects, so specifically thinking about ARIA, whether we're talking about edema or hemorrhage, I think we all know that there's this really interesting dose response effect for E4 carriers. So the higher the dose, the higher the rate of ARIA. It's a bit of a problem. There's actually really great research study published by the Florey that might shed a little bit of light on this in the last couple of weeks. But what's interesting is that there is a huge overrepresentation of E4 carriers in these trials. So 3,385 participants, about 70% of them had some E4 allele when the base rate is much lower. And so the question is, if we have 2 groups that are at elevated risk of Alzheimer's disease, E4 carriers, 70% of the research participants, Black individuals, which are 0.5% of the participants, it sounds like we are trying to prioritize E4 carriers over Black individuals. But what's interesting is which population has the largest base rate of E4 carriers in the first place. Believe it or not, it's Black individuals, followed by Latinx communities, then followed by white individuals. But Black individuals are about 50% more likely to have an E4 allele relative to white individuals. So it really has to make you think. If we are trying to design these studies by powering them for individuals at highest risk, and we're able to do that on the basis of E4, the E4 allele presentation, how is it that we have gone to such trouble to disproportionately exclude a high-risk population with a higher base rate of this genetic variable? Now, you might say there's an issue of ABCA7 that might mediate APOE, but we haven't really studied those genetic polymorphisms to really understand what that mediation looks like. So ultimately, we have a huge problem in terms of diversified recruitment, but this kind of presentation shows that we may not fully understand what fundamental disease processes are doing. So, for example, thinking about ApoE in the context of Alzheimer's disease without considering Black individuals means that we may not understand ApoE in the context of Alzheimer's disease. So you might think, well, okay, at least we've got someone like you, Dr. Jackson, that can talk about representation science, but I've got more bad news for you. The field is pretty fragmented. There's lots of confounds. We don't really know what we're doing when we're trying to increase enrollment of minorities, because what is a minority? And the fact is that it's such a mess that most of the good news that we've been seeing when it comes to diversity might be the byproduct of really charismatic, underpaid CRCs. There's no infrastructure, there's no experts, tools, resources that are generalizable or scalable. So you might find yourself having a bit of a reaction along these lines. You might say, I don't know what to do here. So what I want to do is let's take a step back. Ask the big question: why can't we recruit diversified, marginalized populations in representative amounts, whatever that means, to our studies? It turns out it doesn't really matter what your study design is, what it looks like, or who it's testing, or when or where, whether it is a single point estimate or something that is like a large cohort study over time. You're going to have some combination of these 11 problems involved in your study. And so what we have done at my research center is we've taken those 11 problems and mapped them onto a workflow that is ordered in nature, where you have upstream and downstream problems. The highest, most significant issue is thinking carefully about your sampling frame, all the way down to thinking about specific aspects of study retention. And so what you've got here is a nice recruitment funnel that kind of starts with the broadest reach in terms of who it is that you're trying to recruit, and then moving all the way down to the smallest population of individuals. What's really key to remember here is that when we have detailed protocols for our research studies, in terms of data collection, pre-screening, screening, sharing of information and return of results, that really is only enough to kind of support these 3 stages of the recruitment funnel. Everything else, everything that you see up here, and certainly the retention phase, is left to privilege, social privilege, or chance for individuals to try to reconcile or navigate. So this is one of the big reasons why we really struggle with diversified enrollment, is because we as researchers are really only protocolizing half of our workflow from the participant's point of view. And so there's a lot of work that we need to do here. Now, the bigger question, though, is whether a lack of diversity can tell us something more fundamental about the nature of our science. So I was starting to kind of touch on this with my earlier example about representation in Alzheimer's trials. So historically, when we see differences between groups, we would just sort of assume that these are essentialized or biological. The dawn of scientific racism, the dawn of phrenology, was that that there were these groups that had different outcomes. And the different outcomes happened because God made some groups better and some groups worse. And so I think we are slowly but surely moving away from that and recognizing that there are social and structural factors that really comprise a much larger percentage of the variance that we have heretofore been assigning as biological disparities. Now, I believe that even this presentation is still leaves a lot to be desired. And what we really need to recognize is that the variance that we normally assign to between group differences really needs to be put into this modeled workflow, where we think about issues related to selection, measurement, and implementation, in addition to variance that may be contributed from social inequities and biological disparities. So when you have it this way, you can much more easily map out sources of group differences according to these factors. Now, this might feel a little bit overwhelming, but the truth of the matter is that it also gives you a huge range of possible solutions. And so what's great about this is that most of these solutions are already coming from sources that we understand very well. These are a lot of transportation tools that are popularized in epidemiology, issues of sensitivity and specificity, issues related to differential item functioning. All of these are already well validated and understood, but not yet fully applied to the context of diversity and representation. And so this is really the central point, because what this helps us understand is that, there is no tension between methodological rigor versus equity, rigor and equity and representation. That this framework really suggests that the principles of equity and rigor are part of a common frame of interrogating variance in our research studies. And because rigor in research and rigor in equity are actually unified, we can really leverage a lot of these existing statistical and methodological tools to address problems of equity in our research. But what's great is that the converse is also true. So this is really, really wonderful because it helps us recognize that we really need to start doing things like entrenching ecological frameworks, historical analyses, and other social science perspectives within clinical research studies. So I want to give you kind of one of the major predictions of this particular framework, because it helps us answer a question of what should we do with race, which has long felt like the real third rail, the third rail in our research studies. So we know that it's we have long considered it to be a risk factor for disease. It's often tied to comorbid factors of vasculature, and we use it for one of the three reasons. We use it either as a construct, either as some kind of a variable, or potentially as some marker for racism. But unfortunately, none of these are really valid or appropriate conditions to use race in our research studies. So there's really no justifiable base for using racial identity for anything other than as one marker of enrollment. It's certainly not an exhaustive marker of enrollment. So if we break this down, it really becomes very clear that when we try to use race as a construct, it conflates multiple sources of these variants. When we try to use it as a variable, the same thing happens. When we try to use it as an indicator of racism, it really conflates all five levels, all five sources of bias and error that comprise our research studies. And so what this means is that we probably shouldn't be using this variable in our studies. And so when I get to this point in the talk, usually people kind of react something along like this, like, well, okay, I get that race is a social construct. I know that we're not supposed to use it, but then you're like this, but you're also this Black guy that's talking about how important it is to think about equity. How do we put all of that together? I feel like a broken person. So just quickly walking through it, it's more important to think about your mechanism of action than to randomly compare groups. If your mechanism of action is melanin, then asking something about racial identity makes sense. If it's not, then maybe you need to rethink your research question. There might be a possibility to leverage much more useful group differentiators like access to care, nutrition, health literacy, housing, pollution, things like that. Be very careful about the referent groups and in terms of what you might be normalizing in a situation like this. And instead, maybe consider something like a standardized set of socio-environmental factors. So something like common data elements, which is something that I am starting to explore a little bit more in my work. This really will help you start to spot intersectional diversity, aspects of resilience, building towards a quantified social exposome. And in its best case, if you think about a well-designed set of common data elements, it may help reconcile sort of long-standing problems between domestic health equity and larger principles of global health equity research. So ultimately, race isn't the third rail, but racial identity can only ever be a marker of racial identity. And so what's great is that the National Academies just released a report on population descriptors in genetics research just earlier, like just last month, maybe about 3 weeks ago or so. And there were a lot of really important findings in this. We understand that the OMB, or sometimes known as the census definitions of race, don't really serve science particularly well. And they recommended that we don't use race as a proxy for in any of the cases, and to really pay attention to the implications of group labels. Just as I said, they also recommended a focus on environmental factors and to work closely with communities being studied. And then ultimately that this was a problem not just for researchers, but for lots and lots of folks that are in and around the research enterprise. But what you see here is they actually included this figure about when we should be using race. And just as my model predicted, you can see here that race is disfavored for lots and lots of common studies of genomics. The one exception is thinking about health disparities with genomic data. And if you look at the note here, it really says that there are many worlds where you don't necessarily need to think about race as an associative factor in terms of quantifying or understanding these health disparities. So, I think it's important to kind of keep these things in mind and recognize that we have huge problems here. Now, I'm not just kind of talking from the perspective of somebody who has never made this mistake. I certainly have. There's this study that was published back in 2017 in Age and Aging. And what's really interesting about this particular study is we found something that seems cool on the surface of it. When we were trying to do just a simple correlation between two composite measures of objective versus subjective memory or subjective cognitive concerns, we see that there's this nice negative correlation that replicates everything that you've seen in the literature for white individuals, but there's virtually no correlation when you're looking at Black populations. And so if you look at the data, what you can see is that even when you're looking within the composite, you can see that across the two groups, we see there's a similar level of correlation within the constructs. It's just when you're comparing across the constructs that this problem really emerges. So really, really kind of cool and elegant factor that might support the idea that maybe our measures are not optimized for Black individuals. That's a perfectly valid takeaway here. We matched the sample and actually introduced kind of a group differences in terms of sub-threshold performance or on reports on the geriatric depression scale. And so again, what you've got here seems to be a pretty tidy story, but unfortunately it conflates 4 out of the 5 measures here. And so the big mistake that we made was trying to do a matched sample between white and Black populations. It turns out that this Black population isn't particularly representative. So this matched sample isn't particularly representative of the Caucasian sample that's here that is also not particularly representative of white people anywhere. And so what you've got here are 2 groups that really don't tell us anything about the groups themselves. It tells us that this group of 47 and another group of 47 can be matched on these factors and still find different results. But it doesn't really tell us about Black individuals. It doesn't really tell us about white individuals either. So, what we've got here is a really clear case of how seductive it is to go along with the narrative when it's in line with the things that you expect. And so I just want to just offer a quick word of advice. Please do not cite this paper. I know I'm a first author on it. I know I cite it with a really prestigious group, but because of these concerns, I'm not sure that we can really rely on these results. So instead of thinking about what do I do, let's just pay attention to the Drake rule. So I made a meme because I am down with the kids. And what you see here is the best way to think about it. So Drake is saying, I don't want you to use race as a marker of group differences. What you need to do is use specific exposures and mechanisms instead. And so this is in line with cutting edge and current guidance from the National Academies and genomics researchers. And I think this is a really major prediction of the model that I introduced to you earlier. So what I want to do now is to kind of walk through some of these sources of bias and kind of highlight research studies that show you how my group has tried to overcome or better characterize what's meant here. So our first study, it comes from the world of Parkinson's disease research, where I was approached about 5 years ago by the Michael J. Fox Foundation to try to help them diversify an online study that they had designed. The intent was that by moving testing out of brick and mortar institutions, by moving it out of movement disorder clinics, that everybody should be able to participate and that they shouldn't have a diversity problem afterwards. So at the time, there were about 20,000 individuals that had signed up for the study, and here were the racial demographics. If you can't read those labels, maybe you're looking at this on a phone. It is white for a reason. It turns out that it's not just an issue of race, but if you look at education level, you might say, okay, well, most people had a bachelor's, so that's already a lot. But I want to point out that 25% had a master's degree, 6% had a doctoral degree, and 5.5% had a professional school degree. So what's here is MDs are separated out from the doctoral degree. And so when you add that with a master's degree, we've got about 1 in 3 individuals has some sort of master's or professional degree, so more than a bachelor's degree. And then you can see here that the mode of this distribution is well over $100,000. So you might agree with Jeff Goldblum here, where we say, even though this is a really large sample of 20,000 individuals, this wasn't it. This was not exactly the way to kind of design the study. So we created the Fire at PD study to look at this ordered workflow that I introduced earlier, by focusing on the early phases of this workflow, we thought we might be able to put a dent in that diversity issue. So we had a really broad definition of minority. So it turns out that if you're basically anyone other than Michael J. Fox, you are underrepresented in PD research. And we had a really strong focus on like I said, those early phases, particularly in developing a detailed protocol for the sampling frame and for those early phases of engagement. So we had 8 sites for intervention. 4 did a passive control where they did exactly what they always do. It was a very passive control condition. So we gave not much money and not much time to individuals to try to make a difference here. And so the data are going to be really interesting here. So relative to their own controls, so we looked at the data for 6 months prior to the study and then during the study period itself. What we see here is that control sites, even though it was a passive condition, just by merely orienting to the fact that that diversity was lacking somehow, still saw a huge spike in terms of non-white and Latinx participation into their research studies. More dramatically, we see that intervention sites who did design bespoke interventions for specific populations at a specific time, nonetheless saw a non-specific improvement in terms of a wide range of diversity. So it's worth noting that individuals that are low income or low education here, there's no double counting. So it's not like most of these low income individuals fit into this non-white or this Latinx category. These are white identifying individuals of modest income or a low to modest education. So this is really a clear sign that a rising tide lifts all boats. What we also learned is that what we think of as a single distribution of recruitment over time, it might be better understood as overlapping waves of recruitment that kind of bring in different populations and that will ultimately require slightly different approaches to really maximize a recruitment during any wave. So what I think is happening is that there are 3 waves of recruitment. Wave 1 is the one that many of us researchers know. Right when you launch a study, there's usually like a little bit of a rush, but in the first days and the first weeks of a study, you end up with highly privileged participation that is not typically, it's not very representative. But what's great about it is that it doesn't really require a lot of research or effort. What tends to happen is that most research teams will miss the second wave. So this tends to pick up as that first wave goes down. It's of middling duration. The group is somewhat privileged, but not quite as privileged as that first wave. You might get a little bit of better representativeness, but as you can see here by looking at the recruitment funnel, you're going to have to execute some kind of modest researcher effort. So you're going to have to think about equity. You're going to have to think about building literacy and motivation. What's interesting is that in this wave 2, a lot of these individuals are presenting in the same clinic environments, the same recruitment environments as wave 1. They're just simply not being asked. And so it turns out that modest researcher effort really just means consistently asking people to participate. Wave 3 really reflects a lot of the work that we do in clinical trials today that are that's designed to be much more thoughtful of inclusion and representation and community-based participatory research and detailed engagement. So this is a slow process. The population that approaches tends to be modestly privileged, but it tends to give you the best representativeness over time. It does take a significant researcher effort, so it helps to start the pipeline of recruiting for wave 3 in the early phases of the study when you're still enjoying and you're kind of basking in the glow of this relatively low and modest researcher effort. So what's nice is that if you can design different sampling frames and different engagement strategies for each of these waves, you might have a better chance of optimizing recruitment over the long term. But what about for individuals who weren't recruited to the study? Individuals that reported a barrier that prevented them from studying this. So what we did was that we modeled the FIRE-UP PD study to reflect exactly the barriers that currently existed with that online study that we're trying to help diversify. And so what we found is that when you model those things, but then you track the barriers, what you see is that you don't see a lack of trust as like a primary barrier that stops people from participating. You do see significant endorsements of issues related to time commitment. You do see significant endorsements related to language. You also see the digital divide. What's interesting about the digital divide is that it's not a complete inability to access digital devices. It's just that typically the survey instruments that we use in clinical research are optimized for laptops or desktops. They're not optimized for mobile devices. which a lot of low income individuals have. They have a smartphone, but they may not have a big screen desktop computer that can precisely render very tiny fonts. So we need to be thoughtful about what are the real barriers to participation rather than ones that we simply perceive as researchers. Moving ahead very quickly to talk briefly about measurement error. So this is a deeper thinking about common data elements that I'm working on with Anna Maria Branchino and Olivia Okereke up here. So thinking about population descriptors well beyond the current NASA recommendations. So I'm happy to say that we have a forthcoming AD-RICMAR that might be coming to Mass General Hospital soon. We got an impact score of 14 in February, so I think it will be funded, but I'm not sure. But it's really, really important to start to think about this. So we're going to be bringing on common data elements and really doing a real deep phenotyping of marginalized populations at a nearby federally qualified health center. And we'll ultimately be sharing this and hopefully uploading it to the NIH-CDE repository. What's great about this is we're going to leverage these CDEs in terms of predictive factors for a really cool smart design of research retention at this same FQHC. And so this will help us understand the diversity within diversity and how we can start to capture that and characterize it with well-identified, well-vetted common data elements. A different kind of deep phenotyping, I have been working on the Forever study, which is a DP1 award for the last 2.5 years. And so I want to give a quick shout out to Erin Bennett. I'm not sure if she's still on it, but she's been really, really helping me with phases 1 and 2 of this study. So phase 1 is really designed to, again, do this really deep phenotyping of lay communities. We're hoping to get about 15,000 individuals using a novel recruitment method, which is called relational organizing, in which you characterize an entire social graph and then selectively sample and oversample within it to make sure that you have a representative selection within that larger social graph. The hope is to really, really break the NIH table. So you can see that we're going to be having large amounts of recruited individuals in lots and lots of these boxes. But our early data of our first 2,500 participants or so shows that we have an incredible range of diversity in terms of race and ethnicity, huge diversity, beyond what we typically see in studies, where the median years of education is 16. A lot of people have advanced degrees. You can see here that nearly 1 in 5 has less than that in terms of that. And then income, where I showed you median income was well over $100,000. In most studies, we can see here that we have much more variability and diversity in terms of income. So these are categories that are not reported on NIH tables. We know that they are important for health outcomes. And so we really want to highlight the existence of these things. In addition to that, one of the things that Erin has been helping me out and has been really instrumental on is starting to think about mapping our catchment areas in Alzheimer's disease research, where we are looking where populations living with Alzheimer's disease or populations at high risk are living, and calculating enrollment fractions. So the portion of the population living within an area, so in this case, it's 3-digit zip codes that are enrolling in a study. So you can see, obviously thinking about areas where ADRCs and other centers of excellence are doing well versus where they're doing poorly. But ultimately, you have to keep in mind that these enrollment fractions are still going to be pretty tiny. We're still talking about fractions that are all under 1% of a locally available, viable, qualified population for investigation. So I think what this helps remind us is that we certainly have a long way to go. In phase 2, which is currently ongoing, we are doing a deep micro ethnological study of 20 plus ADRD sites around the United States. We are developing an outreach dashboard and workflow for sites to use. And then phase 3 is to really put them together, to really create a curriculum whereby lay communities and research communities can work together. And we are centered on a group that tends to be intersectionally disadvantaged, which is the idea of trying to prioritize an ongoing partnership between research and lay communities around the needs of trans women of color. And so the idea is to kind of take these findings, create a robust curriculum, and share that to the NIH outreach platform, which is known as ADOR. So I'm starting to run low on time, but I wanted to just highlight a couple more things in terms of implementation and design biases. we often talk about barriers to participation, but we don't necessarily talk about incentives or aspects of value. So this is a recent paper that was just published by Anne Ololoro and Kimi Dahl and myself just a few weeks ago, where we looked at the return of value elements that were developed by Consuelo Wilkins and her team back in 2019. That kind of just highlights different incentives beyond just the concept of money that cause people to want to participate in a research study. So there are 11 categories of these. We know, according to Wilkins, that a lot of these, the most valuable categories for Black identifying individuals are information on the context around genetics, lifestyle risk factors, ancestry, and then obviously thinking about some sort of remuneration for their participation. So we wanted to understand if we looked at gynecological oncology trials from 1994 to 2021, do we see the presence of any of these return of value categories? And so based by the phrasing of that question, I think you know that the answer is going to be pretty depressing. We found ultimately that only 1% of all trials over a nearly 30-year period offered any kind of lifestyle risk factors. There was no trend over time, so this is not something that's getting better. 0% of trials in terms of the public-facing record discussed ancestry or remuneration of any kind. So what we have here is a really significant problem of trial design, or at least the public-facing aspects of trial design, to really respect the returns of value needs of the incentive factors for marginalized populations. So if we can't design an incentive structure and as well as overcome barriers, then we're going to continue to have these problems over time. Very quickly, I wanted to talk a little bit about neuroimaging. So how do we handle emerging technologies? So this is part of an ongoing work that I'm doing with Francis Shen, Susan Wolf, and Francis Lorenz that's thinking about the future of highly portable MRI. And so while broader access is good, while it's easy to see how something like this can be helpful to reaching out to marginalized populations, there are lots and lots of practical concerns about what this might mean and what this might lead to. And so what's interesting is that we are developing recommendations on the ethical, legal, and social implications of highly portable and cloud-based MRI, especially MRI that may be driven by machine learning algorithms and things like that. So it's really, really important to make sure that we start to bring in a completely different set of stakeholders for highly portable MR, because it turns out that you don't have those same structures of supervision and culpability and responsibility out in the field as you do within a typical academic medical environment. So this is coming forth over the next 18 months or so. We're going to be doing a series of papers, an interesting scientific study at the Museum of Science here in Boston, and we'll also be having a conference later this year. So stay tuned on that. The last thing that I want to say before starting to wrap up is that we don't necessarily have to think just about aspects of trial design, trial data, interventions. We don't have to think about the bioethics, but we can actually start to rethink entire systems of doing research, entire frames of research design that may center equity from the get-go. So these are a couple of just launched studies with a colleague of mine, Andy Nierenberg. And so figure one, as you can see here, is a really interesting smart design that really respects patient centricity. So the first thing that we do at level one of the smart design is we ask individuals what kind of treatment they want in terms of trying to treat bipolar disorder. And so the patient gets to pick. They're followed for 6 weeks, and if they don't get better, they get to re-randomize among the other options that are acceptable to them. And so what's great about this is you've got sort of multiple opportunities to understand what patient preferences are, build that into a really efficient scientific design that is statistically robust, and it reflects patient centricity and all the factors that we know are key principles of equity. Beyond that, I'm also working with Andy on devising an entire learning health systems model where you align institutions, payers, researchers, and patients together to really, rapidly improve and accelerate health outcomes. So it's really critical and crucial to be thoughtful around this in the days and years to come, because as we start to iterate and move towards the era of precision medicine, we are going to need much more flexible, responsive models where outcomes are aligned. Otherwise, we're going to be left behind. So in summary, what does all of this mean? there's just a whole lot that we have to think about when it comes to this crisis of underrepresentation in research. We need better frameworks for our research workflow. We've got to find strong ways to really leverage current and emergent resources to improve diversity and representativeness in all of our scientific endeavors. So what it's important to keep in mind is that this is not just for the sake of diversity. This is really a crisis of scientific integrity. We have to recognize that diversity is our floor. It's not our ceiling. This is, we've long moved past the idea that just wishing and hoping for diversity is enough of an aspirational goal. We're sacrificing the scientific quality of our studies with that kind of thinking. At the same time, thinking about principles of justice, equity, diversity, inclusion, we really need to think about quantifying that in order to fit within our world of health and health adjacent care. There is a really strong need for some of the principles that I highlighted in my talk today: common data elements, workflows, protocols. We really need to start to think about precision measurement of these matters if we're going to try to make sure that this works within the world of precision and personalized medicine. Ultimately, this is just the tip of the iceberg. There are lots of contributions from other sectors. I think that this might represent an entirely new field of research, something that might nestle nicely between population health and clinical research, sort of a science of middle sizes, if you will. And then the last point that I want to make is that equity is still going to be a driver of health innovation. Right now, a lot of that is around efficiency and tech. But I do think that, as we start to rely on these big data sets, and as we realize that some data sets aren't as good as others, centering equity to build representativeness will be one of our primary metrics of robustness as we start to move into the era of precision and personalized medicines by the end of the decade. So that is pretty much it. The last thing that I want to leave you all with is just some advice from one of, I think, the great philosophers of our time that is really thoughtful about aspects of integrity and ethics. And that is, of course, MC Hammer, who wrote a couple years ago on Twitter, when you measure, make sure that you include the measurer. So that's my talk. I just want to offer quick thanks to grant support, the Care Research Center, our board of trustees who have a little asterisk next to their name. And that's the end of my commentary. So I just want to say thanks for listening to and taking in some of my science.
Oh my God. Whoa. My head is spinning right now. That was incredible, Dr. Jackson. I have like a two-part question.
Sure.
I mean, in reality, many of us struggle for funding, number one, and we're happy we actually get study subjects to undergo some of the stuff that we, especially in my area, what we do to them. I guess one question is, how do you reconcile, and you may have answered this, how do you reconcile NIH's like tables of, inclusion, where what you project for enrollment needs to be quote unquote representative of your catchment area, right? So they're all focused on race and ethnicity and sex. So you've got to fill out that table. That's the first question. The second is, how do you reconcile, the tremendous value of your research in an environment that is still filled with such disparity in healthcare and access to new promising techniques? That has to keep you awake at night.
Yeah, sometimes it does. But to answer the first question, I think we have to recognize that NIH is certainly well-intentioned with their enrollment table, but ultimately short-sighted. And I think that a lot of what we do in this diversity, like in this era of DEI, might be sort of similarly short-sighted. So what I would recommend is starting to have some honest conversations with your program officers, with NIH officials about that enrollment table, and make sure that if you are looking for a certain kind of diversity, that it is well motivated and well justified. So the biggest problem that we often have, especially in like ADRD research, is we'll look for, say, a cohort of Black and African American individuals to jump into our studies. And then what we realize far too late is that this cohort is not actually comparable to like the white people in our study. And so what we need to do is we need to have like a much more nuanced understanding of what diversity is and why it's important by trying to kind of build all of that together. The answer to your second question.
Wait, so in that table, rather than
I think ultimately the long-term solution is that something like an NIH enrollment table, something like a table 1 in a research report, should creep towards the inferential rather than the descriptive. So we really need to understand who it is that we're trying to represent and why. And so when you start to say, like when you're writing a grant and when you're writing a paper, here is the population that I'm trying to study. So right now, all of us will say, oh, we're trying to study Alzheimer's disease. So we want individuals that are at risk of Alzheimer's disease with the expectation that our study generalizes to that group. If instead we can start being specific, we can say, all right, here's who we're trying to study. Here is our table showing who it is that we were actually able to recruit. We're going to do some inferential statistics on the population, on the distribution of the population, and say, okay, there is no significant difference between the representativeness of our sample and sort of the larger population distribution demographic statistics. And what we would need to do there is make sure that we have a set of descriptors, and that's why I'm pushing the common data elements, a set of descriptors that are intersectional. So instead of just thinking about the kind of relatively modest intersection of race, ethnicity, and gender, thinking like a much more like multidimensional about this space. So that's a long-term thing. In the short term, again, I would follow the recommendations that were specifically outlined by that National Academies report that was published a few weeks ago. And I think that when we see that those descriptors outlined so clearly, we now have like this really high quality official document that you can use to sort of push back against the expectations of NIH or certain reviewers around this. And what's nice is that, in the grants that I've gotten feedback in the last few cycles, I think even reviewers are starting to become a little bit more savvy around this. Not all of them quite have the words to really capture this in detail. But I think we are starting to recognize that, there's more to diversity than just getting, ethno-racial minorities, even in a small amount, or there's more to it than just doing that at screening and not looking at enrollment. The second question that you have, and then I'll get to Dr. Turner, is with respect to, what do we do when we are trying to, we're trying to solve and address these problems within our science, but we're kind of embedded within these larger systems, especially even if you're just thinking about like larger healthcare systems that really kind of continue to push large, like really, I think, egregious inequities that make it difficult for people to get into our studies, make it difficult for us to generalize, make it difficult for us to even characterize some of these samples. So that 5-part model that I put out that talked about selection, measurement, and implementation issues is the way to go. So the idea is we need to recognize that there are huge problems and systems that are kind of advanced at the societal level. And what we need to start doing that is, instead of trying to design around it, we need to really recognize what that variance is doing to our models. And so we need to model it. We need to build it into our study designs. And so if we can't do something about it, then we need to be measuring it. Like those are really our only two choices. And so I would say, instead of thinking like, how can I, as like one researcher with one grant, like go out there and like knock down these huge systems of the patriarchy and of racism? You can't. Like, you can certainly maybe do like a little bit for one population for a certain amount of time, but what we can do, what we should be doing is we should be working to model and measure that instead. In the short term, we need to be thinking about these principles of selection, measurement, and implementation, biases and errors. And we actually have like a very significant obligation to not just measure, but mitigate those factors in our studies. And so this is like I think the final piece of advice is, there is a lot of mess going on outside of our house, but we need to clean up our own house first, because otherwise it's harder to see the rest of that mess. Okay, Dr. Turner, what do you got for me?
All right, and in the 2 minutes that we have left, I realized that this was a 45-minute talk, and it really should be a whole, like session at a conference. So there's so much to talk. But
Yes.
The two things that I didn't hear you talk about was, how does that 5-part model relate to qualitative research?
Mm-hmm.
And then the second thing I wanted to know is, you didn't mention anything about culture or issues around trust. How do you deal with those within what we've talked about?
Yeah, so the 5-part model actually includes a little bit of those things. I just had like one throwaway sentence that I said very quickly that kind of covered both of those things, which is that the 5-part model really requires us to be much more thoughtful about including aspects of social sciences in our putatively qualitative research studies. So instead of just relying on p-values and t-tests and regressions, we need to make sure that all of those data are appropriately contextualized through social scientific theory. So, even if you just think about like ecological models as like a baseline, so thinking about individuals that are nested within groups that are nested within larger societies and systems, that I think is certainly like a really important cross-section that can be applied to this model. And then thinking about issues of trust that tends to emerge in systems like these. And what I would say is that while trust is an important factor, we need to recognize that trust can actually pop up at each of these 5 levels. So you can have a trust issue that pops up at selection, one that pops up at measurement, one that pops up in terms of the design, one that pops up in terms of social and societal structural factors, and one that pops up in terms of understanding really the implications of bioessentialism. So what I would say is that trust doesn't fit in any one place in the model. It's within each of those sections. And maybe what we might need to do is to think about trust differentially. So I know that there are researchers like Derek Griffith, who thinks about trust, mistrust, low trust, and distrust. But what I think might be a better era for the future is to think about trust in these different aspects of variance for the models. So we need to recognize that many aspects of trust are conflated across either like a social issue or a design issue. So some emergent data from my DP1 actually suggests that the low trust that we see for individual participants is not towards institutions. The low trust seems to be for specific for a lack of transparency for specific study protocols. And so that, I think, is a really interesting nuance that is not usually appreciated when we talk about trust, because we tend to talk about trust at the institutional level when we need to be thinking about it maybe at the level of this 5-part framework, which allows you to start to see where the trust is and isn't, and how that might be changing over time.
Sure, and I understand that, and I can appreciate that. But I guess what I'm really asking about is, when you're talking about trying to recruit and retain individuals, and they say culturally, for instance, I do not want to get involved in a research project because of the historic mistrust of people or abuse of people like myself getting involved. So when we talk about all of these different elements that you've mentioned in your model that we have to factor in as to who we are actually getting involved with it, that's kind of like an elementary kind of issue that you have to deal with, not only in the beginning, but all the way through, as to why or why not, why someone or why they would not get involved in your study. Is that part of what you're addressing in your model, or is that fundamentally different from, where we're talking about? Because, bottom line is, if you cannot get, quote unquote, if you don't want to recruit them by race, but if you can't get Black people to trust wanting to be in your model, you're not going to be able to get all of these different degrees of individuals to be involved.
Yeah, so actually, I did cover trust in a couple of my studies in like the later part of my talk, but again, it's moving pretty fast. What we did find is that, again, like if you are looking for research participants in certain settings, trust is a factor, trust is a concern, but it is not a reason why Black and African Americans choose not to participate. So what we have found in Parkinson's disease research in my DP1 is that many individuals of color will cite trust as a concern, but it will not be a primary reason for failing to participate. My suspicion is that we are not necessarily adequately measuring trust as a barrier in the right way. And so that does fit within the 5-part model, because trust can be an issue that is reified at the level of selection, just like you articulated, where it's like, if trust is a factor, someone is or is not going to participate. That may be true, but it's not going to be true for the Black individuals that we usually see in our research studies. That is much more likely to be true for a cohort or a subpopulation of Black individuals that currently do not engage with research whatsoever.
Absolutely. Absolutely true. And that's part of the issue, right? Because we
Right.
do want to have a very diverse population within these certain groups. And you're absolutely right when you talked about, when I saw at least, I'm not going to say right, but I can relate to what you're talking about, where you have such a high level of education. That's part of our problem, is that we're not, we are not reaching a stratified population. We're reaching a very, succinct population that has shares certain social demographic, attributes.
Yeah. So that's, I think for me, the ultimate step forward is to start to think about a quantified social exposome, like really going down on these common data elements, because trust is a factor, but we don't necessarily know enough about the communities that we're studying to know where trust is the problem and exactly how to overcome it. We know from my studies that you can overcome some aspects of trust issues by just asking people. We know that you can overcome some trust issues by offering increased and enhanced transparency for the study. We know that you can overcome trust in terms of retention by staying in touch with folks. But we don't necessarily have a clear idea on what models of overcoming trust work and whether they work relatively equally across all strata within a diversified and minoritized group. The answer is likely to be no, but we don't necessarily have a clear idea of what that looks like. So the models that I said, that I kind of demonstrated, the way that I presented them, you're absolutely right that they don't have the nuance to get into those precise predictors. But my hope is that it will give us enough of a foundation to really start to interrogate those questions.
I absolutely appreciate your answer, and I thank you for that. And I do realize that, again, and given the limitations of time, you weren't able to really expound on that as earlier.
Yeah. Thank you, though. These are great questions, Dr. Turner. I appreciate it.
Sorry, Laura, I had to go to class, but thank you so much for your presentation. I mean, such great, important information, and we can't thank you enough. We'll have to have you back for like 3 more. So again, thanks for attending our seminar series, and check us out at our GW Institute for Brain Health and Dementia. Thanks a lot.
All right. Take care, everybody.